our nephropathologist. She has been with Arkana since 2011, and she graduated from medical school at Wayne State University in Detroit. I then completed a pathology residency at UT Southwestern. After that, she came to Arkana, and she is involved with patient education. She's also involved in some of the social media stuff, and we are really happy to have her here today. What we're going to do is talk about endocarditis-associated glomerulonephritis, which I think is a very important topic because it can look like just about anything, and we'll talk about that. We also want to introduce Dr. Clarissa Casal. Dr. Casal will moderate the chat and actually sort of answer questions so that we can spend a lot of time with Dr. Boyles going through the actual pathology. She joined Arkana just this year. She is actually from Brazil, went to medical school in Brazil, and then ended up going to Toronto to do her pathology and renal pathology fellowships. So welcome to both of you. And we also have two nephrologists that are here. Myself, I'm Dr. Sparks. I am at Duke University, the Associate Program Director, and then Dr. Samira Farouk. We will kind of be asking the questions that a lot of the nephrologists want to answer. And we are really excited to be here. Samira, do you want to say hi?
Sure. Hi, everyone. Good morning. Thanks for joining us on this Saturday morning. Last month when we did this, it was another perfect day in New York City. There's another one today. I'm a transplant nephrologist at Mount Sinai in New York City, and really excited to be continuing this monthly series and a follow-up to Dr. Boyles' outstanding presentation last month. And so looking forward to getting started here. This session is being recorded, so it can be viewed afterwards on our YouTube channel. We'll share the link to that at the end of the session. And if you haven't already done so, if you can please complete this short survey to tell us a little bit about who you are, and so we know who's joining these sessions. And so we'll go ahead and get started. So Dr. Boyles, whenever you're ready.
Okay, I'm going to share my screen. All right, here we are. Can you hear me okay?
You sound great.
Okay, so I'm Christie Boyles, everybody, and we're here today. This is a part 2 session. Last month, we looked more generally at bacterial infection-associated glomerulonephritis. Well, today we're going to shift our focus towards endocarditis-associated glomerulonephritis. And if you missed it, I do encourage you to go back and watch that recorded session. But we're going to discuss the paradigm shift that has occurred. And really, there's been an evolution in renal complications of infectious diseases. So let me just briefly, in less than 5 minutes, introduce this topic and also recap where we left off from last month. So there's been a decline in the incidence of actually streptococcal glomerulonephritis. We're now seeing a much broader array of microorganisms with predominance of staphylococcal infections. And also, the demographics have changed. These infections are now occurring, and instead of the younger age population, we're now seeing an increased prevalence in older patient populations. Staph infections, which can range from superficial skin infections to deep-seated infections, including endocarditis, have been noted in the expanding elderly population. These patients are, they have increased comorbidities of diabetes and heart disease, and they're at increased risk of infection with their increased use of cardiac devices, central lines, indwelling catheters. We've also noted staph infections in the young adult population with the rise of intravenous drug use. And like we discussed last month, these infections are often active and ongoing during the occurrence of the glomerulonephritis, rather than your prototypical post-streptococcal glomerulonephritis, in which you had your infection, then an infection-free latent period, and then the occurrence of a glomerulonephritis. So this concept is really important. We do not want to refer to this entity as a post-infectious glomerulonephritis, but rather the terms infection-related or infection-associated glomerulonephritis are more appropriate. Also, this concept is critically important, especially with infective endocarditis-associated glomerulonephritis, because sometimes the presentation of glomerulonephritis will actually coincide with the first clinical recognition of infection in some patients. So if your pathologist tells you that the biopsy shows a post-infectious glomerulonephritis, then you're really going to miss the opportunity to consider an active infection as the etiology. And last one on terminology specifically related to infective endocarditis. The initial literature describing nephritis associated with infective endocarditis were primarily based on autopsy studies. Some of these were over 100 years ago during the pre-antibiotic era and even the early post-antibiotic era. And the historical divisions that you've learned about, acute bacterial and subacute bacterial endocarditis, those were really based more on clinical grounds, reflecting the severity of the disease, also the virulence of the infective microorganism, the presence or absence of underlying cardiac disease. Those terms are really no longer recommended in the current era, in part also because other infectious organisms beyond bacteria are now implicated. So the term infective endocarditis is used. And the statistics I'm going to show and share with you today related to infective endocarditis associated glomerulonephritis are more from the current era. A lot of the textbook information, it is outdated, but there have been more recent autopsy studies, case series, case reports, and recently Arkana Laboratories collaborated with Mayo Clinic, and we produced a large clinico-pathologic series on renal biopsy-based findings of infective endocarditis associated glomerulonephritis. So that's some of the information I want to share with you today. Our initial study was published in 2015 in Kidney International, and then that was a cohort of 49 patients. The cohort was expanded to include 62 patients published in a book chapter in 2017. So really, Drs. Chris Larson from Arkana Laboratory and Sammy Nasser from Mayo Clinic, those are the gentlemen that really came together and decided to perform this collaborative study. And I think a lot of great information has come from it. So let's recap where we were last month. On my screen, you can see here, I have a renal biopsy up. This is an H&E stain. And this is what we saw last month. Last month, we looked at this pattern, which we called a proliferative and exudative pattern glomerulonephritis. The exudative pattern was used because of the intracapillary neutrophils, which are very abundant within the glomerular capillary loops. And we saw that this pattern is very characteristic of infection-associated glomerulonephritis, but we also learned this can occur superimposed on other renal diseases, such as diabetic nephropathy. We also saw a case in which we had mesangial proliferation only and no endocapillary proliferation. So there was a spectrum by light microscopy. We also saw by immunofluorescence, while strong C3 staining is very characteristic of what you will see by immunofluorescence with infection-associated glomerulonephritis, you can also see cases with C3 only or immunoglobulin and complement together. And those immunoglobulins can vary. We've seen IgA, IgG, so there's a spectrum. Also by electron microscopy, we saw deposits within all the locations of the glomerular tuft. And while those large subepithelial hump-like deposits are very characteristic of infection, their absence does not include infection as the etiology. And in fact, in endocarditis associated glomerulonephritis, you will only see humps less than 20% of the time on renal biopsy. So by looking at all these contrasting cases last month, I hope you were able to appreciate the spectrum and just really realize that no single morphologic finding is pathognomonic for infection-related glomerulonephritis. It really does also depend on the clinical picture and just putting together the whole constellation of findings to collectively favor infection. So let's take a look at our cases. Let's recalibrate back towards a normal looking glomerulus so we can appreciate the changes with endocarditis associated glomerulonephritis. So here's a PAS stain. And like we saw last month, both the H&E and the PAS stains are very pink in appearance. But the PAS is easy to recognize because when you start to look at the tubular epithelium, the tubular basement membrane is pretty prominent with the PAS. It just looks like you've taken a little pen and you've circled all of the tubular profiles. Also, the PAS stain highlights very nicely Bowman's capsule within the glomeruli and the glomerular basement membranes. So the glomeruli appear more crisp and you're able to really appreciate their morphology. When you have a normal looking glomerulus like this, you can appreciate the open capillary loops, and you're more easily able to identify the various cells that are present within the glomerular tuft. The endothelial cells, you can see their nuclei protruding into the capillary loops, like here. The mesangial cells you'll see surrounded by PAS positive pink mesangial matrix. And then the podocytes are occurring on the outside of the capillary loops. So here's our normal looking glomerulus on PAS. Let's switch over to our first case of endocarditis associated glomerulonephritis. And just like before, we're altering somewhat the clinical history so that there's no concern for patient confidentiality.
And just before we get started, if anyone has questions, please share them in the chat with the host of the meeting, and one of the pathologists will answer them, or we can get those over to Dr. Boyles to answer live.
So here's our normal pathology look. We're going to switch over. This first case is a 30-year-old female who does have history of IV drug use. She presents with acute renal failure. She is noted to be febrile. Blood culture was performed and it was positive. She had a staph bacteremia, MSSA infection. Also was noted to have a tricuspid valve infective endocarditis. Vegetations were noted by echocardiogram. Now, interestingly, her complement level was within the lower range of normal limits. So that's a little bit different than what you might think about with your typical infection, but we will talk about that more. So here's our PAS stain, and we can see how prominent within the glomeruli Bowman's capsule is. So this is a really good indication that we are looking at our PAS stain. But these glomeruli look different than what we just saw. The difference is the capillary loops are not as easily identifiable as open and patent. We're now seeing increase in cellularity within the glomerular capillary loops. Some of these cells are mononuclear cells. It's a little bit hard to tell on the PAS stain, but some of them are also neutrophils, like here. Remember, the neutrophils are one of our polymorphonuclear leukocytes, meaning that their nuclei are multilobated. You will see anywhere from 3 to 5 lobes within the neutrophil nucleus. We'll be able to see that better on the H&E. But basically, we have too many cells within the glomerular tuft, so this is an endocapillary hypercellularity pattern. And as you scan around and look at the several glomeruli that we have on the sample, all of them are showing that feature. Now, also note the background. It is not uncommon to see with infective endocarditis some background tubular injury and interstitial inflammation. Do you notice this material within the lumens of the tubular epithelium? Kind of this translucent material. So last month we discussed how red blood cells do not stain on a PAS. So this is also why we are able to see that we're on a PAS stain, because these red blood cells are really translucent and they're not staining red like you will see on the other stains that we use in renal biopsy interpretations. Let's just switch over to the H&E stain. We're looking at the same case, but I just want to show you the difference of that area that we were just at. See how obvious it is now that we have red blood cell casts within the tubular lumens? This tissue also looks pink, but we're seeing red blood cells staining, and the tubular basal membranes are not as prominent. So this is an H&E stain. And this is your characteristic kind of background look with endocarditis, where you'll have a little bit of background inflammation. You will see red blood cell casts often. The majority of patients will have hematuria, and about half of them you will be able to find these red blood cell casts on the renal biopsy. Now, the tubular epithelium is also showing injury. We have some cytoplasmic vacuolization, some areas of cytoplasmic thinning. But as we look more towards our glomeruli, because those are the compartment of interest here with our topic of glomerulonephritis, this is where you can appreciate on the H&E stain the endocapillary neutrophils. So like we discussed last month, this looks similar on first glance. We have a proliferative and exudative pattern, glomerulonephritis. Now there's a difference here in this case, because if you really start to look around, you're going to catch another observation in just a few of these glomeruli. On the bottom aspect of this glomerular tuft, we can see Bowman's space is open, and that's the normal appearance. But in this top left-hand corner, do you see this increased cellularity? There is a little bit of proliferation that is also occurring outside the glomerular tuft. And this is actually a cellular crescent. It's very small, but we do have a little cellular crescent here. Now this pattern of a proliferative glomerulonephritis, this is inclusive of endocapillary proliferation with or without crescent formation. This was the pattern that we saw in roughly 40% of our cases of endocarditis associated glomerulonephritis. So it's a pretty common pattern. Here's a little bit of necrosis on the H&E stain. About half of the cases of proliferative glomerulonephritis actually also had some degree of crescent formation as well. So this is a not uncommon finding with endocarditis associated glomerulonephritis. So any questions on the light microscopy? We really reviewed the main histologic observations with this case on light microscopy.
I think that was a really great review. Again, if anyone has any questions, please share them with us in the chat and we can try to answer those.
Well, I'm going to ask a question, and this is kind of on something we learned last month. And remember you said that PAS you can't see red cells?
Correct.
What do those casts look like on a PAS stain?
Yeah, I'm going to switch over and show you. Here are the red blood cells. They're just translucent. You can see the silhouette.
Okay, so it's kind of see the silhouette, but they just don't come. They're not as bright.
They don't stand out bright red. That's right.
Okay, nice.
I've seen in urine microscopy there's those ghost red blood cells. Is that something you might use here?
No. So when red blood cells become aged, they will hemolyze, and then they will actually look translucent even on the H&E stain, as well as other stains that. Let me find an example. Stained red blood cells, including the Jones and the trichrome. Sometimes as the red blood cells age and hemolyze, they might start to lose their red appearance and you'll see more. I mean, I'm not completely sure that's the case of what you're seeing on the urinalysis, but on tissue microscopy, the red staining will start to kind of fade with age as the red cells hemolyze. Like there's probably a little bit of an aged red blood cell cast. See how some of these are starting to turn a little more pink?
Okay, yeah, I see that. It's like a bouquet. I'm gonna get a picture of that one right there.
I'll move the arrow.
It's like a little rose bouquet there. I like that. Someone was asking on the chat about whether or not there are vascular changes that you see with this. So we kind of focus on the glomerulus. We focused on looking at the red cell cast and a little bit of tubular damage, but what about vascular changes?
Yeah, in this case, there's really no vascular change to comment on. This is a 30-year-old patient. We did not see any sort of arteritis.
So that would, you're not going to see much vascular pathology in of itself with endocarditis, but you might see it just because of other comorbidities.
That's right. If you have underlying hypertension, you will see arteriosclerosis in the term, the form of intimal fibrosis, but you will not see a necrotizing arteritis. And that is a point I'm going to make on our next case as well. So that's a good question to consider. What are the vessels showing? So remember how last month we talked about this known association between staph infections and IgA dominant infection-related glomerulonephritis, where staph infections will often cause a staining pattern to include IgA. I'm switching over to immunofluorescence to show you this. So this is interesting because, IgA, there is an association between IgA and staph infections, and staph infections are the most common causative agent for infective endocarditis associated glomerulonephritis. So you would think, maybe I'm going to see, I'm also going a little bit slow here today. So we're going to switch over to immunofluorescence and show this case. The IgA stain is what we will start with. So by immunofluorescence, we stain for 3 immunoglobulins. We stain for IgA, IgG, and IgM. We're going to start by looking at our IgA. And remember, there's always a little bit of background autofluorescence that will be there. So you can see the tissue silhouette. You can identify glomeruli.
And this was another question from the chat earlier on. I held it until now.
Okay.
And it was differentiating IgA nephropathy from infection-related GN.
Yeah, and that's something we had talked about yesterday as well. I mean, it kind of comes back to appreciating the full clinical context. You can have some degree of endocapillary hypercellularity with IgA nephropathy, but you would not expect a diffuse global involvement of all the glomeruli, and that really strong exudative pattern is more characteristic of infection. So there can be overlap by immunofluorescence alone, for sure, but that's why you need the other modalities, the light microscopy, the EM, and the clinical context. You would expect maybe a young male that presents with hematuria to be IgA versus a diabetic with a cellulitis and active staph infection. When you have strong IgA staining in that case, you know, it goes back to that's the more likely scenario for an infection-related IgA dominant immune deposition pattern. So what I'm showing you here, though, is we've been scanning around looking at a few glomeruli, and notice that there is no staining. These glomerular tufts are negative for the presence of any sort of immune deposits. Though you can see that silhouette, you can appreciate the glomerular morphology. This is your normal background autofluorescence, and we don't see any staining. So this is another way that endocarditis-associated glomerulonephritis is very unique among other infection-related glomerulonephritis. IgA staining, even though staph infections are the most common infectious agent on blood culture, IgA staining is seen in less than 1/3 of cases with infective endocarditis. So that kind of known association doesn't really happen as often with endocarditis. So the A was negative on this case. Let's switch over and look at the IgG, see if there's any staining by that immunoglobulin. Now you can see that the mesangial regions are starting to look a little brighter than what we saw before, but it's not this 3+, knock your socks off look. And that's the thing, there is a spectrum. We rate the immunofluorescence intensity on a scale of 0 to 3. 0 being negative, like our IgA was, and 3 being, extremely bright and abundant. In this case, there's more sparse staining within the glomerular tufts. We can see some mesangial staining, some capillary loop staining, but it's very sparse. So this is the thing, not everything is a 3+ staining intensity. This is more like a 1+ IgG. It's a little bit wimpy. But you can see that it's not completely negative. So you probably score this about 1+. So can everyone appreciate that this is not completely negative, but it's a little bit underwhelming, perhaps?
Yeah, looks like there's a little bit of green, not totally black.
A little fluorescent. So let's switch over to the C3 on this case and see what the glomeruli show with that. Now the IgM I did not show, this was negative. Now with the C3, we're starting to see more abundant little granular fluorescent features coming through here with the granularity that's brighter than what we just saw with the IgG and more abundant. And in this case, we're seeing both staining within the mesangial regions as well as along the capillary loops. I'm going to try to scan around and just see other glomeruli in this case. And like we discussed last month, sometimes when you have mesangial and capillary loop staining, it can be a little bit harder to tell where you are. If you have a mesangial only pattern or a loop only pattern, it is a little bit easier to tell your pattern of positivity. But I think you can appreciate here that the central portions of the glomerular tufts are tending to pick up the deposits more. And also some of this granularity is pretty coarse and large. Sometimes you will see that when you have presence of humps, even though only about 20% of the time on EM will you actually find those hump-like deposits. So we have a positive immunofluorescence study here. The C3, following the trend like we saw last month and characteristic of infection, C3 in this case is the most prominent immunoreactant and it is the brightest. So should we look towards our electron microscopy to see what we have there? Or are there any questions by immunofluorescence? Kind of scanning around, we had several glomeruli to
I was
look at.
going to make just a point to everybody. We're having problems getting others to be co-hosts. So since we have some pathologists that can answer questions, we turned on the chat. So please don't ask a ton of, ask questions. We'll try to get to them as quick as we can, but we're only able to have one person as host. So now Clarissa Casol can answer some of these questions that we have.
Okay. Well, I'm going to switch over to our first case, the electron microscopy. We've already looked at the light microscopy with a proliferative glomerulonephritis. We saw a rare crescent or two. We have immune deposition, C3 predominant. And then by electron microscopy, I know at first glance, it does seem like a lot is going on sometimes, but I always start orienting myself by just looking for these glomerular basement membranes. Also, we can see within some of the capillary loops, like I'm pointing to here on the right side, we do have the presence of some inflammatory cells. This looks like a neutrophil. You have the multilobated nucleus, some cytoplasmic granules. Some of the capillary lumens contain red blood cells, which do not stain red, of course, by electron microscopy. They look more dark black, like we're seeing here. And then on the outer aspect of the glomerular capillary loops is where your podocytes live. So right here, for example, this is a podocyte nucleus that I'm pointing at. Here's the podocyte cytoplasm. And then you can see the little cytoplasmic extensions in the form of foot processes coming off around the outer aspect of the capillary loop.
That's not bad looking podocyte right there.
Yeah, not too bad. Looks good. You actually see the foot processes a little bit. Sometimes you have some effacement. The effacement will vary when you have glomerular injury. You might not much.
Quintet of RBCs up there too.
Yeah, they'll often kind of pack together like that. So looking for I start by finding where I'm at in the glomerular tuft. Oops. And then I also try to look for deposits. So along the outer aspect, subepithelial aspect, I'm not really seeing any deposits occurring between the podocyte and the glomerular basement membrane. On the inner aspect, you have your endothelial surface, your fenestrated endothelium. It's usually quite inconspicuous, but if you had subendothelial deposits, they would occur there. But look at the mesangium, the top left area, this is mesangial matrix, and you can actually see, even hiding here in the corner at low power, these dark mesangial deposits. The EM does correspond to what you saw by immunofluorescence. So if you saw more of a mesangial loop pattern by immunofluorescence, that's similar to what you should see by electron microscopy. Even at the bottom aspect here of the mesangial region that's shown here at the bottom, you can see these dark deposits occurring within the mesangial matrix. Let's go a little higher power to appreciate some of these mesangial regions, because you can see here the very dark electron dense deposits within the mesangial matrix. We're very high power here, so we're just seeing a few of the podocytes at the top kind of overlying the mesangial region. So you can orient yourself to where you are. And then other areas of the mesangium, as you look around, in some places you're seeing fewer deposits, just like we had variability from one portion of the glomerular tuft to the other on immunofluorescence. The same is true for EM. We have a few deposits in this image within the mesangial matrix, but it wasn't as abundant as that last picture because we're kind of looking around at different areas. We had to kind of hunt around on this case to find there are some subendothelial deposits here. This is a higher power look at a glomerular basement membrane. We have the podocytes on the outside. You can see little foot processes. Some of them are a little bit effaced, but you can see the cytoplasmic microvillus transformation. We know this is a podocyte. So on the other aspect, this will be your subendothelial aspect. And we do see these dark deposits occurring here along the subendothelial space. So there are subendothelial deposits here as well.
Now, one thing you mentioned is that you had to hunt around to find this. So can you give us a sense for how frequent this is occurring? Is it throughout? Is this just a very rare event, or is it happening more frequently?
Yeah, well, I was going to show at the very end, but most of the glomeruli in endocarditis-associated glomerulonephritis, they will have mesangial deposits, the vast majority, over 80%. The
Does that
7
correlate with severity?
well, it correlates with by what you're seeing by immunofluorescence. More often mesangial staining.
Well, I'm talking about
And
clinical severity. Like if you have,
no,
it's
because what
not.
we're going to see is just because you have a deposit on electron microscopy, you're not able to say for sure if that's a deposit representing a complement component C3 only, if this is an immune complex deposit with immunoglobulin and complement staining by immunofluorescence. So they're all going to come together, and we're going to less often see subendothelial and subepithelial deposits, less often see humps, more often we're going to see mesangial deposits. But you can see mesangial deposits across the spectrum of proliferative glomerulonephritis as well as other patterns of endocarditis associated glomerulonephritis. So we're going to get to a few of those other patterns here in just a moment, and I will show you that as well. Here we are, we found our one hinge region hump right here. We have right where the mesangium and the capillary loop kind of branch off from one another. We can see this deposit occurring right here. So this is a subepithelial, larger hump-like deposit that's occurring right here at the hinge region. An infection really loves to have these deposits here, but in endocarditis, you will only rarely find them. If you kind of scan around also, look, there's a little tiny subepithelial deposit right here as well.
Can you repeat that one more time, what you just stated?
Yeah,
You see
so,
it more in
well,
one than the other?
yeah, so I think what I was saying was, the subepithelial hump-like deposits, when you have those, they're very characteristic for an infection-related glomerulonephritis. But when you don't see them, that does not exclude infection as the etiology. And specifically with endocarditis, in that infection-related glomerulonephritis, you will very rarely see subepithelial humps. We only saw them in about just under 20% of our cases of endocarditis associated glomerulonephritis had humps.
So in infection related, you see it, but not endocarditis. To me, those are fairly synonymous. What is the reason for that?
Yeah, I don't know if we have a good reason. We're just kind of showing our observation. We studied.
This is just what we've seen over.
Patients,
Okay,
and that's
got it.
what the trend was. So just kind of making note of what's there. So this is our summary of our first case. We just saw a proliferative glomerulonephritis, and given the clinical context, this IV drug user with tricuspid valve infective endocarditis. This fits with an endocarditis associated glomerulonephritis. Now, proliferative is inclusive of both endocapillary proliferation with or without crescents. And like you were saying earlier, Matt, how it's interesting how you will almost always see C3 staining on the biopsy within the glomeruli. And they're often the C3 is very bright, but the complement doesn't always correspond. The blood, serum complement levels are only suppressed in endocarditis about 60% of the time. So
yeah, which is something we always say it always is. So
yeah, and it's not an always.
That's the frustrating thing about it's like a D-dimer, it's like can be.
So it's helpful when it's low, and you should
exactly same thing. Yeah.
But then when it's not low, that doesn't exclude the possibility. And in this patient, interestingly, the complements were not low, and that's the trend in about 40% of cases of endocarditis associated glomerulonephritis. Now, also her presentation was acute renal failure. That's a very common presentation. About 80% of patients will present with acute renal failure, rather than a typical nephritic syndrome of what you saw with the prototypical, childhood post-streptococcal glomerulonephritis. There's a little bit of a difference. And then, the
patients that get a
valve,
kidney biopsy.
Yeah, and
You're
the
talking about.
Valve was involved here. All the valves of the heart can be involved with endocarditis associated glomerulonephritis. But you're right, just get a biopsy when in doubt.
There's a question about how you would characterize the staining for C3, 2+.
Yeah, that was about 2 to 3+. It was pretty bright. You had some variability, definitely brighter than the IgG. And yes, it was pretty intense. We saw more intense cases really last month. Some of these are going to be, not as bright as others. So
Does anyone have any questions about that? There's another one here about C3GN and how you can differentiate that.
Last month we looked at that. We looked at that question as well. You're right. Sometimes on the immunofluorescence alone, especially when you have C3 only staining, you can ask yourself, why is this not a C3GN? Well, that's why it goes back to the full constellation of findings. Typically with C3GN, you would expect more of a membranoproliferative pattern by light microscopy, not proliferative and exudative pattern, although not
You're
always.
not going to see those neutrophils.
And not often we're going to see as exudative of a look.
Those humps probably wouldn't be
also
present
with,
either.
just the clinical picture with C3GN, you should expect persistent hypocomplementemia for weeks and months. With an infection-related process, you would hope this would be more transient, and that you could, have resolution of the glomerulonephritis with treatment of the infection. So it goes back to the clinical picture, and sometimes if you can't tell, genetic studies are needed to understand which entity you're really dealing with. It can be sometimes hard to separate those. All right, I'm switching back to light microscopy here because we're going to look at our next case, our case 2. All right, I am not seeing the image because I need to switch this over. Okay, so I'm switching over to a PAS stain of our second case. This patient is a 60-year-old male with history of hypertension. He has a mitral valve replacement and does have a left-sided mitral valve vegetation on echocardiogram. He did have a positive blood culture for strep viridans, and his C3 was suppressed, but also his ANCA serology was positive. So we did a renal biopsy here. He did have acute renal failure and hematuria as well. So I like to, just kind of take a low power overview of our renal cortical biopsy here, and we see, just even on low power, you can appreciate we have some differences from one glomerulus to the next. We have here glomerular tufts that look relatively normal in the center without any endocapillary proliferation, without any extracellularity, and then we have some other glomeruli that look completely different. So we notice here, not only do we have some increased endocapillary hypercellularity, but we also predominantly have these extra glomerular cellular proliferations in the form of crescents. Hey Shri, if you're online, can you run me a few batteries for my mouse? It's going quite slow here. Okay, so we have these crescents now in this glomerular tuft. And actually, I will say, I take this back. The neutrophils in this case are more occurring within these areas of necrosis rather than occurring in the capillary loops. So that is another thing on first glance you have to kind of make note of. When you see neutrophils and you see a glomerular tuft, it doesn't necessarily mean that you're dealing with an endocapillary proliferative process. We have here areas of necrosis and cellular crescent formation. So that's why we're seeing the neutrophils. If you look at the glomerular tufts without crescent formation, we do not see a proliferative component here. So this is more of a crescentic pattern glomerulonephritis. I'm getting my batteries changed out for my mouse really quickly.
I think that crescent deserves a few exclamation marks. Like when the crescent takes up half of the glom, it's definitely not a good sign.
All right, let's see if this works better. All right, there we go. It's moving too slow for me. Sorry about that. This is what happens with the live presentation. Let me switch over to the Jones stain because we're going to see here just how impressive these crescents are.
Now, those gloms that you were just on were in the same biopsy, which didn't look that bad.
That's right. So interestingly, not all cases of infection-associated glomerulonephritis will be 100% glomerular tuft involvement.
Mm-hmm.
Like this case, we have some obvious glomeruli that are extremely injured, and then we have other glomeruli that are normal, and that happens. But if you look as a whole at all of the glomeruli in the sample, you can see many of them have these necrotizing lesions and glomerular tuft disruption, and then the really large cellular crescents. So when you see a crescentic glomerulonephritis, their common association is with ANCA-related disease. That's what we all think about on, first glance of crescentic glomerulonephritis. But I really want you to not only think about, crescentic glomerulonephritis in the context of ANCA, but I want you to think more about this as being just a severe form of glomerular injury really the most severe form of glomerular injury that can occur histologically. So rather than a crescentic glomerulonephritis being a specific disease entity, think of this as a pattern of glomerular injury, because this can occur not only with ANCA, but also with infective endocarditis. And I mentioned to you about 40% of the cases will have a more proliferative glomerulonephritis. This case would be characterized as a crescentic glomerulonephritis. And this pattern occurred in 50%, so half of the cases. The most common finding was a crescentic glomerulonephritis. So this is what I was saying, we have mimics here. See how we have cellular crescent formation in the form of the cellularity occurring outside the glomerular tuft, and the very pink stringy material here is the fibrin deposition. So we have, rupture of these capillary loops, and we have extravasation of inflammatory mediators into Bowman's space. When we have fibrin, we can see that there's stimulation of this epithelial proliferation as inflammatory mediators, plasma constituents enter Bowman's space. And then over time, the cells of the crescent will kind of evolve from a more cellular look to a more fibrocellular look as you have replacement by collagen. There's a lot of red blood cell casts in this case. They're really throughout the renal biopsy core.
So interesting that some do and some don't, and
it's very variable. But
I wonder if like those crescents is like that's the actual nephron from that tube, that glomerulus.
Yeah, I'm sure those red blood cells are kind of streaming down from these glomeruli. That would make sense. And you can see the Jones stain, which we're looking at here, which highlights really nice.
A lot of cells in there. Look at that.
Yeah,
down
the
on
glomerular
this.
base membranes, you can see little pieces of them fragmented in the glomerular tuft. So this is a very destructive histologic form of injury. And again, because we're not seeing endocapillary proliferation or mesangial proliferation away from the areas of crescents and necrosis, this is why we're calling this a crescentic pattern glomerulonephritis.
And just to be clear, that crescent is all coming from the parietal epithelial cells encroaching in onto the glomerulus?
Yeah, I mean, it's a proliferation of cells. There's kind of some debate, the exact origin of these cells. You have visceral and parietal epithelial cells, but you're stimulating proliferation also from the, plasma constituents coming into Bowman's space and interacting here as you have rupture. The blood elements that are normally contained in the glomerular tuft are now coming in and kind of contributing to this crescent formation as well. So,
and all those packed cells that are lining the interstitium and tubules up in that, I guess the mostly interstitium, what are all those cells?
So you're seeing next door, there's a lot of inflammation. Is that what you're looking at? The inflammation?
Yeah, it's like, I guess kind of like they're at the concert watching the
oh yeah,
watching the crescent.
Point. It's not uncommon, especially with the severe glomerular injury pattern, to see a lot of background interstitial inflammation. But what we're not seeing is what we saw 100 years ago from autopsy-based studies. We're not seeing microabscess formation or infarcts. Those kind of older described renal manifestations are not really prevalent with renal biopsy infective endocarditis associated glomerulonephritis. So I'm showing you this very severe pattern of glomerular injury. And remember where I said there's morphologic overlap with ANCA, but unfortunately there's also serologic overlap. This patient I mentioned to you had a positive ANCA serology. And that actually occurs in 25% of the cases of endocarditis associated glomerulonephritis. The patient will actually have a positive ANCA serology. So once again, we cannot use just one finding alone to decipher between two similar entities. We have to take the clinical picture together in context. Also, we're going to look at the immunofluorescence on this case and see a staining pattern that also raises the possibility of infection. So someone asked earlier about vessels and involvement. Now, in this case, we're in the vessel sampled, we are not seeing much arterial intimal fibrosis, but I wanted to make note specifically that though we're seeing a crescentic glomerulonephritis, which can occur with ANCA, we are not seeing a necrotizing arteritis or a necrotizing arteriolitis or a medullary angiitis. These are other renal manifestations of ANCA-related disease. We're not seeing those manifestations in the setting of endocarditis associated glomerulonephritis. That's another kind of distinction. All right, I'd like to switch over to immunofluorescence to show what we have on this page. My mouse is really slowing me down here. Sorry about that. Endocarditis fluorescence. Are the glomeruli that you're looking at preserved, or are they
Every time you
involved
switch to
with
this, it does
necrosis?
this. Yeah, one of the
Yeah, sorry,
interesting
my
things someone
mouse-
mentioned.
My mouse was deciding to take forever.
I guess when someone commented about a selection bias that, you know, if the clinical picture fits with someone with endocarditis, low complements, and they might not biopsy because you're going to treat them anyway. And so the biopsy series that we all report, we all see, are they kind of, you know, really, this is a very severe pathology that we usually don't see. So the spectrum of what's reported might not be typical of what really is happening in most patients that we don't biopsy.
Yeah, we probably don't know the true incidence of endocarditis associated glomerulonephritis. That is true, because we often do not biopsy them. But
Is
this
it possible
why it
there's
goes
some
back to-
there's subclinical?
Well, this is why it goes back to
damage?
where sometimes the glomerulonephritis is the presenting feature of their infective endocarditis occasionally.
Yeah, that is when the nephrologist really breaks the case.
Yes, and this happens, you know, and there's, you know, some studies showing up to 20% of the time of nephrology consult, infective endocarditis was not diagnosed. Autopsy studies show sometimes up to 38% of patients are not diagnosed until autopsy, so it can be missed. Patients can be culture negative, they can be afebrile, they can have normal complement, so there are pitfalls everywhere. I'm just showing here the fibrinogen stain by immunofluorescence. Remember how we had all that fibrin material within the glomerular tufts by light microscopy? Well, when you have the fibrinogen stain by immunofluorescence, it will highlight the areas of glomerular necrosis as well. So this is why it becomes important to know when you switch over to look at your immunoglobulins and your complement, where you are at in the glomerular tuft, because you can have some entrapment of immunoglobulin and complement in areas of glomerular tuft destruction. This can occur even with cases of glomerulosclerosis. So you just have to make sure you're interpreting everything correctly. I just show you that to just, you know, make mention of it. Can be sometimes challenging on the renal biopsy interpretation to make sure that you're accurately interpreting what you're seeing. Here's our IgG, switching over. And it's pretty underwhelming. We're not really seeing, you know, this is not a linear pattern like an anti-glomerular based membrane antibody. I mean, that could have been in the differential if you had no history at all. Most of these glomerular tufts that are preserved, like this one here, where the glomerular tuft is pretty intact, there's really not much going on by immunofluorescence. I'm going to try to find another glomerular tuft here. Now this one, you can see a silhouette that we have a lot of crescent formation. Now the fibrin will not highlight with the IgG, the cellular crescent will not highlight, but you can just see the glomerular morphology is a little more disrupted. And it looks like on first glance, maybe there's a little bit more staining, but if you look, some of this granularity you're seeing are actually in podocytes. We have just about trace, very sparse, finely granular staining in the glomerular tuft. It really is underwhelming.
And the reason that you're calling those podocytes is because it's fairly focal and not.
Well, the podocytes tend to have these large protein resorption droplets within them.
Okay, got it.
And so they will sometimes have that kind of clustered globular look, and we just know that's a podocyte with a bunch of cytoplasmic protein resorption droplets. Here's probably a more preserved mesangial region. What I'm trying to show you here is what a trace, very wimpy, you know, barely positive immunoglobulin staining pattern looks like. And we looked at a lot of cases last month with 3+ intense staining. This is just showing, you know, this is within the spectrum of post-immune disease, and that you have few or little immunoglobulins. The IgA, the IgG, the IgM are either negative or they look like this. So, you know, we take our immunofluorescence findings and we'll typically subdivide those into either immune complex type or post-immune. We don't really have a third category of C3 only. So immune complex, meaning we have a complex of immunoglobulin and complement together. Well, in this case, we do not have immunoglobulin. It is extremely weak to negative. But we do have strong C3 staining in this case. So you really wouldn't want to put this in the category of immune complex type because we don't have complexes in immunoglobulin. It does fit more into the post-immune, but just know there's a lot of inconsistency and controversy in the literature about how to use these terms. But in general, when you have a crescentic glomerulonephritis with more C3 staining in the glomerular tuft than you would expect with your typical ANCA-related disease, that is an opportunity to consider infection. Also, sometimes you will have bright immunoglobulin staining, though there was not any mesangial expansion or endocapillary hypercellularity. By light microscopy, sometimes by immunofluorescence, the immunoglobulins will really stand out and highlight much more than what you will see with your typical post-immune disease, and that's an opportunity to consider infective endocarditis as well. I really wish I had 2 more hours to keep going because there's so much more to share. I'm just going to show you this.
And maybe right before you move on, repeat that again about the ANCA, that you just really briefly encapsulate that. It's a very important point.
Yeah, so ANCA serologies can be positive in 25% of cases of endocarditis-associated glomerulonephritis. So we have a serologic, clinical overlap between these entities. Also on light microscopy, there's morphologic overlap. You can have a necrotizing crescentic glomerulonephritis, and often it will be more post-immune. About 40% of our cases of crescentic glomerulonephritis were post-immune, meaning we had C3 only without immunoglobulin component. It was not an immune complex type. So, these are different morphologically, and the clinical, I'm kind of losing my train of thought a little bit, Matt, I'm sorry. What did I say last time? I don't remember.
I think that
there's an overlap clinically and morphologically. So when the immunofluorescence, though, does show stronger C3 staining than what you would expect, or when the immunoglobulins are stronger than what you would expect with your typical post-immune ANCA, that's when you think of endocarditis.
And that is exactly what I want. That was a point right there.
Yeah, and I know I'm saying more than your post-immune, but when C3 staining is very bright, or when your immunoglobulins are very bright, that's when you think about endocarditis. And on the EM, you should see very few deposits with an ANCA-related disease. The EM of endocarditis-associated glomerulonephritis, even in cases of crescentic glomerulonephritis, you will often see mesangial deposits as well. So that's another feature that, on first glance, they looked similar by light. Even by immunofluorescence, there's overlap. But on the EM, that's another opportunity to really look for deposits, more abundant deposits than what you would expect. Like even here, there are some dark deposits in these small, non-expanded mesangial regions. This is another opportunity to consider infective endocarditis.
So yeah, all these points here are really important, and almost like the secrets of the pathologist, the nephrology. I mean, it takes time to sort of, understand these subtleties.
Yeah, I mean, you don't want to put a C3 only into an immune complex type. That's why they kind of get forced into the post-immune. That's why I was saying it's not a great subdivision we have with renal pathology with the immunofluorescence into these typical categories, immune complex versus post-immune. C3 only, you have a hard time deciding where to put it. It's not an immune complex, but it's not completely immune negative. So that's why there's a struggle, but ultimately, it is more of a mimic of a post-immune pattern. But that's why the EM becomes important and the clinical picture becomes important. This patient, had a vegetation of a mitral valve and had a bacteremia. So it all fits. And also the therapy is extremely different, completely different. ANCA is a very severe disease. It can be very destructive in the kidney. So you want to immunosuppress. But if a patient has an infective endocarditis, then immunosuppression can be extremely dangerous. So that's why it also becomes really important to just take that extra step and really trying to decide, does your patient have an infection? This is what I wanted to show. Here, the summary kind of patterns. We looked at, just looking at our cohort of 49 patients in our Kidney International series, and then the expanded series that was published in the book chapter, Bacterial Infections in the Kidney. Most of the patients had a crescentic pattern by light microscopy. Proliferative was the close second pattern. I did not show a case of a mesangial proliferation only, but we had a case similar to that last month in which the light microscopy only showed mesangial matrix expansion of mesangial hypercellularity without any endocapillary occlusion and without any crescent formation. The immunofluorescence microscopy often will show C3. Now I'm just showing the percentage of cases with positive staining. I'm not showing on this graph here the intensity of staining. Something to note is that C3 is not only the most prevalent immunoreactant on cases of endocarditis-associated glomerulonephritis, it's also the brightest intensity, usually a 2 or 3 plus stain intensity. The immunoglobulins are only in about a third of cases, even IgA, despite staphylococcal infections being common. But the intensity is less, 1 to 2 plus range. And interestingly, IgM tends to be the most fluorescent, bright immunoglobulin when it is present. So that's just kind of an overview of some variability of the staining characteristics. And by EM kind of going along, we had a lot of cases with C3, so we would expect a lot of cases with mesangial deposits, and that's exactly what we see. The subendothelial, and especially hump-like deposits are less common, but just keep in mind, nothing is 100%. Less than 10% of cases had 0 deposits, just like on C3. 5 or 6% of cases had 0 C3 staining. So that's really important to make note of if you happen to have that one patient with absent staining altogether.
Thank you so much. I think we're just at the top of the hour here, and that was outstanding, just like last month. So hopefully we'll have you back again soon. So thanks everyone for joining. We did share an evaluation form in the chat. If you can fill that out for us, it's just 2 quick questions. And please feel free to share any feedback with how we might improve our sessions for the future. And all of these sessions will be uploaded to our YouTube channel, which we've also shared in the chat. And until then, see everybody next time. Have a good rest of the weekend. Thank you again, Dr. Boyles, and to the entire Arkana Labs team.
Thanks, everybody. We enjoyed it.